Okay, I think that was pretty lively there at the end, and just what we needed, actually. I feel as though we're really in good hands. And when I got wind of this about, I think it was November, maybe a little earlier, but the coalition participated in some meetings, and we submitted a letter of support and things like that. I really wasn't sure how well this could get pulled together. And when I read through the slides, I was just very pleased to see just how comprehensive it is. And I think everyone is really harmonized over the need for the all-payer claims database and improvement here in Virginia. So what we're going to do now, and I think we have about a half an hour. And don't be shy, but we're going to ask questions of the panel presenters. And we have a microphone here in the center. So because we are recording this today, if you can please go to the mic and address your question. And since I have some burning questions, Sarah, you say, how can employers, we need the employers to get involved. We need to amend their contracts. What's the sense of that? I mean, how do they do that? What's the timeline?
You can, if you're going out for contracts or for a request for proposal, or you're going out to enter into a new contract, that's always a good place to start. When everyone enters into a deal, you know what you got. But who says you can't amend the contract? I would say go amend the contract if this is an issue for you that you think that your provider will not provide your information. I would bet, I know we've got a lot of people that are working hard and that are willing to send the information if they get permission from you. If you're not self-insured and you're a user of the insurance company's plan, they're going to get permission from you to submit from a self-insured point of view. I've already been asked by some vendors for permission to submit our data, and of course we're saying yes. But the bottom line is, I think that if you start a new contract, put it in the new contract provision, and if it's something that you're doing that's a work in progress, you add addendums and amendments to your contract all the time. Why not for this? And so you get to talk to your wonderful legal department. And they'll be very responsive, I bet.
Thank you. And Sarah, that's good. That's very good. That's encouraging. What about the cost to do that? Do employers have that ability? Do they feel that you have that ability to just stop what you're doing and amend your contract?
The cost agreement that the stakeholders have reached as part of the negotiation over the bill was 40% from the health plans, 40% from the health systems, 20% from the collector of the data, VHI. So it's up to the plans to decide how they're going to allocate this cost, but this is data they have. There is going to be some cost for directing it in the format in a standardized format to VHI, but in the scheme of things of healthcare spending, this is not a significant cost item.
Okay. So also, if we're looking at the cost and the initial investment, the 40% through the health plans, 40% through the hospitals, and then 20% through VHI. That's an initial investment. What will it cost going forward to analyze and to start benchmarking? Would any of you like to comment on that?
Michael.
Sure. Through the processes, this is a Verizon moment. Can you hear me now? Yeah. Okay. Through the process of aggregation and providing the information for analytical tools, either online or in other reports, those costs generally will be initially set up. So really what we're talking about is employers or other people's costs to access that. And that'll be through subscription agreements, maybe getting special reports and custom reports. The shorter answer is the more folks that request information, the lower the cost. The more we're able to work with the employers individually or in groups through such as the VBCH and other groups, we can develop things that they can subscribe to on a routine basis, which greatly lowers the cost. But there will be costs, but I can't estimate where they are now. But again, the more the merrier.
So could we start out with some standardized reports? I mean, we know pretty much the chronic disease, we know certain surgeries, we know, where some of those opportunities are. Can we talk about some standardized costs so then that at some point then it can get down to the consumer level so they can also be a part of improvement?
I mentioned that'll be part of the advisory council's work in collaboration with Michael going forward. We're at the implementation phase, we're at the launching point. Michael has developed a good estimate of what the rough budget might look like. Roughly speaking, it's about $1 million a year to operate these things, a little more perhaps. Michael's going, yeah, up a little bit. But a year from now, we should have a good idea of real costs. Once he's completed the RFP process, we have a vendor selected and all of that. And then we'll be able to translate that, since that's the back office infrastructure cost, if you will, maybe $1.5 million. Then we'll be in a position to define the data products and what the subscription cost might be for the various stakeholders to get access to the data. Wisconsin's experience, I think, will be helpful in defining what those standard products might look like that the major purchasers in the health systems might like.
Great. Andrea, question?
I am interested in whether there is any room for public and professional comment on what kind of data is collected or goes into the ACPD. Will there be room for?
Well, I'll start and anybody else. Essentially, this is based on claims.
Thank you.
Mm-hmm.
Okay, so the limit is anything in claims can come in. And as a matter of fact, anything relevant will be coming into claims. So it's very, very detailed information. Anytime there's a claim from a physician or laboratory or surgeon or hospital or ambulatory surgical center and pharmacy, all those things are coming into this.
Okay.
Those are standardized. They're based on the standard transactions between providers and the payers, and then payers on their output. So that's a very large amount of information. But as far as adding additional things, the law is actually very specific, and the agreements are very specific that if a payer isn't collecting this information, they're not going to be required to come back and start collecting that again. And that's just a fairness. It allows us to standardize across to other states and actually across the nation.
Great, thank you. And just a couple of follow-ups. Are prescriptions included in a claims database, prescriptions that are made?
Pharmacy, yes.
Wonderful. And when we're looking at, this might be a question for you, Sarah, in terms of tracking chronic diseases, is there a selected set of chronic diseases that are going to be tracked, or are we, again, will it be a comprehensive looking at all diseases?
Well, that's from the health department's perspective. We're sort of working on those pieces of the reports that we'd like to see to start. As part of the data usage and submission agreements, there is an exhibit connected with that details some of those public health reports that we'll be looking at. Certainly our epidemiologists are really interested in some of the chronic diseases and illnesses that we've been tracking in that field. As Michael mentioned as well, the data that's coming in, there is some information in the legislation as well that any information that comes in, and no matter how it goes out, that we have to ensure that it's not able to be, and the words are actually in the legislation, we cannot reverse engineer it.
Okay.
So we're working on what types of reports we would like to see from the health department's perspective, starting with those sort of simple, and I understand no chronic disease is simple, but those simple pieces that we can track to start. And again, I think the advisory committee will help us with some of those too, as well.
Great, thank you.
The only thing else I'd
Go ahead.
add is the law is actually very specific about certain types of disease and chronic diseases that there will be reports on, which are picked up: cancer, diabetes, cardiovascular disease, and a whole host of low birth weight babies and things like that.
Okay.
But I would like to see over time, you got to start somewhere, and this is a great start, but as things come along, that I would think if you're getting all the claims, that over time, they could look to, and you could certainly do an ad hoc query once we get up to that, to do anything that's special for you. So I would like to think that whatever's in the claim database, ultimately, anything that cannot be re-engineered, et cetera, that you could ultimately get it out either as a separate ad ad hoc report where they start out with the most common or the most expensive areas first. For instance, for us, we might be interested in, okay, I've got lung disease. Is lung disease more prevalent in Southwest Virginia, and I got more allergies and Tidewater? Maybe that's where I'm going to emphasize my common health initiatives, which is our wellness piece. So there's a whole lot of data out there that if I get him to integrate my vendors, then I can see all of this kind of stuff, and it would be very helpful.
Great. Thank you very much.
And then to play on that, since I have this question, the wish list, has been to integrate the, the patient-centered medical home, the wellness and prevention type of data. And is that just out there somewhere? Is it being brought in as a claim in that essence because of coaching and that capability as we reform payment?
One thing you can measure, and this is true in Wisconsin and other states, is where we have a standard of care that applies to a chronic condition. Diabetes is the most popular example, whether the hemoglobin A1C test is done with a proper frequency, whether there's a foot exam done periodically.
Right. Mm-hmm.
You can test, you can do a report card on physician groups that evaluates whether their patients that they see, are they getting that standard of care? So when you have a standard of care for managing a patient condition and a chronic condition, you can evaluate using the APCD whether that standard's being met. But it doesn't in and of itself, it won't distinguish between care provided in a patient-centered medical home versus care provided elsewhere.
You'd have to know
You'd have to pull by the vendor.
Type of provider you're looking for, and if they are identified as a patient-centered medical home or accountable care organization. And that's one of the things that we've read are things that are yet to be determined and to be worked on going forward, because at this point that's sort of at a fairly young stage, and so we'll just have to see how it all evolves first.
I can tell you one of the things we're going to be looking at it because it is our data. We're going to have costs, our actual claims cost, which it's not going to be the same if you put your data in. I won't have your actual claims cost, but I can pull mine. And so I will be looking at the cost-effective quality initiatives of the delivery channel. And so we will know who those providers are. It won't be, but we would have to select who they are, and then I'd have to run some comparisons. But that's one thing about being self-insured. You get your own data, so you can do that or have Michael do that at a cost, right? This helps cover your cost. Ad hoc reports. But you got to be very clear on the data elements that you want. You got to know what's in there, what do you want, and what is it going to show you? Because you don't want to make mistakes and run on the wrong report. So you really got to work with your insurance companies, work with your provider, and figure out what data you want, extract the data, and see what it tells you.
Thank you. We have a question from the floor. Could you please introduce yourself as well?
Yeah, sure. My name is Sanjay Mittal. I am representing eHealth Objects, which is a health technology company based in Richmond, Virginia. My question is, I heard that we're going to be basically providing information, de-identified member data. So the question is, when the claims data is being sent to APCD, would that be de-identified when it's being sent, or it'll be de-identified when it's stored, or it's going to be de-identified when it's accessed? So are we going to have the real patient identifiers in the APCD database or data warehouse, or it's going to be all de-identified?
The information coming to us initially will have identifiers.
Okay.
The voluntary program that we have requires that the information as it goes in is de-identified.
Okay, got it.
It's
Thank you.
de-identified as to patients.
Right,
So
it's
Chris
a patient.
Bailey isn't going to be,
Right.
you can't query for Chris Bailey's experience, but you will be able to query for a unique patient and their experience. It just won't be identifiable to a particular individual.
Okay, thank you. The other question is the standard format. I heard that it's going to be X12 EDI transactions when the claims data is being sent, mainly for the medical claims.
The newly developed ANSI X12 Pactor post-adjudication claims, data repository standards. We'll be mapping the information so it doesn't come in as a transaction. And I'm getting geeky here for you if you want to get up and get something cold to drink. But the information won't come in as a transaction like it would be if you were transmitting back and forth, but it will come in essentially a flat record file following the sequence, following the definitions associated with that.
Okay.
We're actually having the folks that have developed the standards work with us to be the first state to comply as closely as possible with those.
Okay, well, thank you so much.
Okay, sure.
Hi, I'm Gretchen Watson from the Health IT Consortium for the Mid-Atlantic and New England states. And I've heard you talk about the advisory board, which sounds like it's nicely underway. And I was just wondering if you could comment on the work group that a couple of you mentioned, where you are with that and how you're planning on selecting people if you haven't already.
The part of the legislation, sort of one of the latter pieces of the legislation calls for us to, once we sort of have the bones of the APCD in place, to put together a work group, and this is in partnership with the Health Department and with Virginia Health Information, to look at healthcare data across the state and the amount of data that's collected, what data is collected, and is there a way we can consolidate that. So we have not gotten too detailed into examining that piece of it yet. I expect that in the March sort of time frame of 2013, we'll start digging into that a little bit more and probably look to forming that work group probably a little bit the same way we did the advisory, APCD advisory committee. And the way we started off with that is sort of kicked off with a stakeholder interest group we pulled together and had a pretty large conference call one day and then a pretty large in-person meeting one day with folks who were typically interested in that, and then sort of started narrowing that down to those who would actually participate. So I think we'll probably get started with that in the spring of 2013.
Great. When you say stakeholder group, will you be including some healthcare consumers?
Absolutely.
Great. Thank you.
Thank you. Next question.
Good afternoon. I'm Greg Pete with Optima Health. I had a question. What are you going to do about employers that provide insurance to employees across multiple states? You're just going to pull the data in for the Virginia-based employees? So that's what they extract.
Part of the value of using the standardized submission format is as other states have all payer claims databases, there's a potential to share and put that information together.
Hi, I'm Barbara Wallace. I just wanted to say thanks to all the panelists. I think in the spirit of collaboration, you all know how much time it takes to collect a group like this to educate us and to be present and give up half a day in Williamsburg. So I wanted to thank you all. Before I ask my question, we recently did a membership survey for our coalition, and we represent 350,000 covered lives. And that includes primarily self-insured employers, but also fully insured. When we ask questions about data, a good majority of our employer members said they were collecting data and using data to make purchasing decisions, which was a good thing. However, when we ask how many were integrating the data and analyzing it and integrating it, only 14%. So we are very interested in the all-payer claims data. Many of our members are interested in data warehousing. And my question is, do you feel like this all-payer claims data is something that you would give advice to hold off on any type of data warehouse among a coalition or a group of employers to wait and see what happens over the next year with the all-payer claims database, including those fully insured employers that I'm talking about? So just comments maybe from Sarah. She's the largest employer in the state. So, but as you look at other, particularly mid-size or smaller employers who are just beginning to sort of ask the questions around data.
From my point of view, I think data warehouses are expensive. You've got to have the talent, you've got to have the hardware, software, but the talent to run it. And that adds up. And so from my point of view, I think we've got a data warehouse here. It depends what it is you want to extract, like actual cost. You will not get, that's going to be a challenge for you. If that is the most important thing for you, then you need to talk to your group. But if trend line, what the actual diseases are, all that other detail, he's going to have a ton of it. So I would encourage as many people as possible to try the all payers claim database first before you embark on a separate one. And if it doesn't meet your needs, tell them what it is that you need that they don't have. Okay? I think cost will be you're going to have some standardized costs. You're not going to have actual cost coming back to you. Where if you're self-insured, you would have your own. So I would, my personal recommendation, and this is just me personally, I know how far along they are. I'd wait to see what they have to see if that meets your needs. Then you don't have to staff it up, and you'd benefit from all the state, not just your group.
I'd echo that. One of the constituencies we had very much in mind in putting this together was employer groups that wanted to work on quality and health improvement priorities. And if the APCD we've designed here and work together to set up doesn't meet that,
you need to know it.
Then we need to know it so we can fix it, because that is absolutely the key constituency we had in mind.
I appreciate that, and I think that what we need to do is make sure that the education, like these sessions today, are getting to a broader audience. And, you know, maybe along the first quarter of 2013, we need to make sure this is our first effort on the coalition to try to educate our members and guests on all payer claims database. And I just challenge others to do so. But thank you all.
I'd like to address one thing real quick. Is for self-funded employers, if you have one carrier and you are not trying to integrate data, like Sarah said, you can make arrangements with your health plan who administers your program, and it depends on how you set that up, what else you have to do. But you can get actual cost data in that, if that's your own data. But if you want to integrate it and compare it over over the norm or the other, see how you're performing with the general public, then the APCD will give you that information for utilization. And standardized costs have been effective in other states where really you're trying to compare, say, utilization, and the costs, sometimes the standardized costs even out things, so you're not distracted by variations in costs from one region of the state to the other, and they're leveled out a little bit, and you can focus more on really what you're interested in analyzing. So sometimes it does help to have the standardized costs.
And I do think that point is particular. The one thing I just did a data dump on was ER visits. I don't know about you, our trend is 2.3%. What's going on with that? 75% of that is based on utilization, 25% is on cost. But when I look at it regionally, I think, oh my goodness, it's the rural areas, that's what's driving it. But you know what? It's not. It's Tidewater and the peninsula and the Shenandoah Valley Central area, and it's certain agencies. So I know where I have to go coach to teach them on how to be using emergency rooms, because only 38.8% of the utilization is proper utilization of the emergency room. So by digging down in that data, looking at regional information, I can go do something about it.
Thank you.
One more question?
I'm Carissa Taylor, and I'm with SAS Institute. In recent years, there's been some interest in predictive analytics and forecasting tools, and we've seen Medicaid agencies and private payers looking at things like how much diabetic care will cost me in 1, 3, or 5 years, rather than being reactive and saying diabetic care is costing me X amount of dollars. What opportunities and interests do you think Virginia will have in terms of future directions and predictive analytics and capabilities to help reduce cost and forecast different scenarios?
Well, I think that would certainly be where we would want to go. As we've mentioned, all of us have mentioned so far, I think we still are in the infancy stages somewhat, so we're moving toward what we've designed so far. And just as we had the conversation just a few minutes ago with Sarah and the lady who asked the other question, we're interested in hearing about the additional pieces and parts and things we should be adding to this, but I would certainly say that is the direction we will, and Michael can speak more to this probably, but that certainly is something in the direction we want to go in the near future. We want to get this up and running and everyone see the value of it and start getting some standard reports and some information flowing out of the APCD at first, and certainly we want to look at those predictive analytics over time as well.
We'll be starting with historical information. It's looking like we'll get 2 years of historical information to start off, which we're very excited about because it allows us to see where we were. As the data starts flowing on a regular basis, we'll be able to see where we are now, and it's only a logical thing. People want to know what may happen later, and you use all that data to do that. So the answer is yes. I agree with what Debbie said, is that's typically something you build in the concept so you can do that. So you have the tools to be able to do that, and you move to that over time.
We would definitely be for it.
Yeah.
And just from an educational standpoint, do you see their benefits, do you see potential benefits of linking the APCD with HIE data to enhance those analytics and make them more personalized and more proactive?
Yeah, absolutely. That's been experienced certainly in Wisconsin. When I said the APCD is a great pointer, but if you want to dive into the care delivery process and modify care in real time, you need to tie in the real live EMR and the HIE data. So absolutely, going forward with these, we're going to have to pair these two up, the HIE effort and the APCD effort up.
And I can tell you from the perspective of the Health Information Exchange, and Department of Health has sort of ownership of that as well. One of our future plans is to once we have the Health Information Exchange up and running, and that is called Connect Virginia in this state, once we have that up and running completely, and we do have our first, we call them nodes, that has come online to the Health Information Exchange, and that's the Inova Rio has come online and using the Health Information Exchange. But eventually, what we hope to do is allow access to the APCD through the Health Information Exchange. So that will be a service that will be bolted on or added to the Health Information Exchange.
So that will be front end?
That would be part of the front end, yeah. That would be the front end, the way you would get to the APCD. So those are conversations we have to have down the way, but there's definitely a connection there.
One thing I want to, this picks up on something Laura Lee said that I think is an important distinction. The HIE that we're designing is a way for different providers who are taking care of a patient, for that data for that patient to flow back and forth across a standard highway for the care providers. It is not a clinical data repository of every patient experience in real time. The only comprehensive view of actual patient experiences is going to be the APCD. That's why they complement each other.
Mm-hmm. Yep. Thank you.
Well, guess what? We're perfectly out of time. Did you have one question? Go ahead. Take that liberty.
Hi, yeah. I'm John Deertoller. I'm from Optima Health, and thank you very much. It's been very informative. A little bit of just a statement, and I think this is probably the best venue to do it in. You know, so often we fill out RFPs and so forth about, you know, consumer tools that we create from a health plan perspective. And the one thing that we're often asked is, can you give us some insight to your quality of your network? And, you know, if you can normalize the cost and you can standardize the quality criteria, it would be very beneficial. There wouldn't be redundancy and there wouldn't be confusion from a consumer perspective on a physician practice or provider, you know, expertise. So, you know, each one of us health plans try to go out and we try to score either by dollar signs or by, you know, stars or whatever it is to try to give you a performance around a network. And it's very costly, and it also creates a lot of angst with the providers. If there was a third party that could do it and had the complete data set, so that, you know, in some markets I might be the majority, in other markets I'm the minority. And I don't really represent that doctor's practice very well in some situations. So going to me is not always the best place to get the information. If you can do equality and set those standards it would be very beneficial, I think, to a consumer, especially as they move into a consumer-directed healthcare. And as we're all focused, and I know Evaluate comes out a lot and asks us about our consumer tools, it shouldn't be at the health plan level. It should be, in terms of rating the quality of a provider, it should be when the whole entire data set is that they're being evaluated. That's just my point. And thank you very much for your time.
Wait, do you have a comment back?
I had an amen.
An amen. Oh, wow, perfect. Okay, well, I want to
It's not fragmented that way.
Sorry?
I said I agree with him. It's not a fragmented database. You're not doing it on a segment here. I like the holistic approach.
Which is one of the motivations for the provider community to support it. So we had a
See?
place to do it right, and do it once.
I encourage more dialogue over this, and we can, take your emails and maybe look at some other ways to exchange information, but let's just keep this going. It's been a great session. I appreciate your time during this learning network, and we're adjourned. Thank you. And I want to definitely thank our panel. They were just experts in their field. Thank you.